Welcome back to the MoCA Prep course. In the previous lesson, you were welcome to the course and got a feel for how we'll help you prepare. Now, it's time to go deeper. In Lesson 1.2, we will explore what the MoCA truly is. Not just its name or reputation, but its clinical purpose, its role in modern cognitive screening, and why it's considered a gold standard tool. This will help you understand the real-world importance of the assessment, which is essential if you're going to use or interpret it correctly. MoCA defined, a cognitive screening tool with purpose. The Montreal Cognitive Assessment, MoCA, is a brief standardized tool developed in 2005 by Dr. Ziad Nasruddin in Montreal, Canada. It was created to detect mild cognitive impairment, MCI, a condition where memory and thinking skills are starting to decline, but not severely enough to interfere with daily life or function. What makes it stand out? While other cognitive tests like the Mini Mental State Exam, MMSE, existed before MoCA, they often missed early signs of dementia or subtle decline. The MoCA filled that gap. It includes tasks specifically designed to challenge brain areas that decline early in conditions like Alzheimer's disease, Parkinson's disease, and vascular dementia. This makes MoCA an early warning system, catching problems before they escalate into major functional impairments. Why is MoCA used in clinical settings? The MoCA isn't just for research or hospitals. It's used across primary care clinics, neurology offices, rehabilitation centers, mental health facilities, and even in telehealth settings. Here's why. Fast administration. Takes only 10 minutes. Broad cognitive coverage. Tests multiple domains. More on that in future lessons. Highly sensitive. Catches early-stage issues others may miss. Objective results. Helps guide referrals and treatment decisions. Clinicians use the MoCA to screen older adults showing subtle memory or reasoning concerns. Track changes over time, especially in progressive conditions. Support diagnoses of cognitive disorders. Guide family discussions about safety and independence. So if you're preparing for the MoCA, know that it plays a critical role in clinical decisions that affect patients' lives, care plans, and long-term well-being. What the MoCA measures, cognitive domains break down. The MoCA isn't a single memory test. It's a multi-domain assessment. Each section targets a specific area of brain function. You'll learn how to master each of these areas in coming modules. But here's the big picture. Cognitive domain, what it tests: attention and concentration. Focusing on tasks and switching between ideas. Executive functions: planning, decision-making, problem-solving. Memory: short-term recall and delayed recall. Language: naming, sentence repetition, fluency. Visuospatial skills: visual perception, drawing accuracy, spatial awareness. Abstraction: recognizing similarities and patterns. Orientation: awareness of date, location, and current situation. These domains are not just academic concepts, they're closely linked to real-life skills like driving, managing medications, handling money, and remembering appointments. Knowing how each domain connects to behavior and function is key when interpreting MoCA results, and that's exactly what you'll gain in this course. Testable insight: the clinical threshold and adjustments. This section focuses on what learners are most tested on when it comes to understanding the purpose of MoCA. The clinical threshold. The MoCA is scored out of 30 points. A score of 26 or above is generally considered normal. Scores below 26 may suggest mild cognitive impairment depending on the individual's history, education, and other factors. Educational adjustment. If a test taker has 12 years of education or less, 1 point is added to their final score to avoid bias. This is a highly testable detail. Learners must remember this adjustment rule. Example: raw score, 25, education level, 11 years. Adjusted score, 26, considered normal. This adjustment ensures fairness across diverse populations, which is why it's emphasized in exams and training. Misconceptions to avoid. As a future test taker or administrator, don't fall into these common traps. It's not a diagnostic test. The MoCA does not diagnose dementia. It screens for cognitive dysfunction and prompts further testing or referrals. It's not about intelligence. The MoCA checks function, not IQ or education level. Scoring is strict. Partial credit is rare. You must know the scoring rules and stick to them exactly. We will discuss the official scoring system in depth later, but for now, understand that objectivity is key when administering and scoring the MoCA. The role and purpose of MoCA. In this lesson, you learned the MoCA is a short, highly sensitive cognitive screening tool developed to detect early signs of decline. It's used widely across clinical settings to guide treatment and referrals. The MoCA tests multiple cognitive domains, each of which connects to real-life functioning. The test is scored out of 30, with 26 as the standard cutoff, and includes a 1-point education adjustment if the person has less than or equal to 12 years of education. The MoCA screens but does not diagnose cognitive conditions,